write
Yes,
except my name or something very, very easy.
yes, of course. Okay, so I think we are live now. Guys, can you please confirm? Are we on?
Yes, doctor.
Okay, great. So let me welcome Dr. Ilham Mounssif. It's a real pleasure that we have you today, another member of the Zucchini team. And let me tell you first that our group is a huge fan of your group members, every single member of your group.
Thank you very
uh,
much.
and we have a reason behind that. You'll know in a little bit in few minutes. You'll know why we are huge fans of this. Um, First of all, let me see if this is working. Let me introduce you properly. Dr. Mounssif graduated from the University of Bologna in 2007. This happens to be my year of graduation. So this is really something. She received her master's degrees in periodontology and implantology in 2014, University of Siena, and the master's degrees of forensic dentistry, which was so interesting to know, a very interesting branch of science, forensic dentistry, in 2017. She worked as a researcher with the Professor Zucchelli. Of course, she's a prominent member of this amazing team and the amazing work they are producing since 2008. And now she's a professor and a tutor of soft tissue management, the program of Bologna University, one of the best programs in soft tissue management. We are so proud and happy to have you with us today. Um, Let me tell you a little bit about our education club. We started almost a year ago. It was June 2009. And the reason why we are a huge fan of your work is that the first session started with a review of yours. And then we continued studying the reviews you wrote in Periodontology 2000. In the edition of 2018, there was a lot of beautiful reviews and a lot of science that we learned from. Around 22 reviews we did sequentially. So the guys really became a huge fan of your work and of you in person. We discussed almost 2 papers per week. So now after 45 weeks, we're almost done 90 papers. Usually they are presented by the guys themselves. We are established in the MSA University, Modern Sciences and Arts University in Cairo. They are young residents and interns and fresh graduates, teacher assistants, some of them. They used to present the work themselves, and we had some good moments during this year. And I personally learned a lot from this. I learned a lot from them and from the papers we read together. And it was really a very successful and interesting experience. We are still going on, of course, since the lockdown. We've been doing this online. We are really fed up with the Zoom lectures and so on, but it was really a learning experience, and we continued learning during this tough time. And here we are continuing to have the great people like you with us today in the Education Club. This is how much it grew. And I would like to let you talk a little bit about yourself. How did you start? How did things go?
First of all, congratulations for your amazing work, hard work, 90 papers. You did it very well.
Thank you.
So you told everything about my career, let's say, because I started even before my graduation to work with Professor Zucchelli and the team that I'm in now, and since then was a continued pursuing of excellence, let's say, in perio and in peri-implant management of soft tissue. So I'm so grateful for the chance to be part of this group, of course, because I've learned from professor, but as well from my, let's say, senior colleagues, but they are not senior. I'm so happy to be here with you today to share my professional knowledge that I've collected over the years. So for me, it's very exciting, and since I've become part of the committee of the masters that we are running and that we ran the last 2 years, my job was more challenging, more exciting, because we have to to teach, sorry, to students. So every day is a continuous challenging for me to learn more and to go deep in every topic.
Yes,
So that's it. And I have also the other passion, that is forensic dentistry, but this is another, that is another story.
You chose this actually. You chose to start this master's.
Yeah, yes.
Mm-hmm. Oh, okay,
Yeah.
it's very interesting.
Yeah, a lot.
So if you'd like, we can start right away with the screen sharing and the presentation.
Okay, sure.
Yes.
No, sorry. Share before. Okay.
Yes, we can see it now.
Okay. So, hello everyone. Good evening. I would like to thank Dr. Nada for this invitation. It's a great pleasure for me to be here and to be part of this group. Very talented and very interested in this topic. And I've chosen a very interesting topic, in my opinion, because usually we are not so used to see complications or issues, especially during conferences in which everyone would like to show only successful treatments. But in my opinion, it's very, very important to share, especially complications that for sure everyone have to face during daily practice, because the more you practice, you perform surgery, the more complication you are going to see. So, and I hope you will enjoy it. So, and at the end we can share some discussion or doubts with you.
Yes, we'll be looking forward for that.
Okay. So the performance of surgery by nature is correlated to some issues that clinicians have to face during daily practice. Some of these issues we can define strictly as complications, but other issues can be defined as complications due to medical errors or medical treatment. So just to talk the same language, I would like to start with these two basic definitions. The first one is complication, that according to the medical dictionary is a difficult factor or issue, often appearing unexpectedly and changing existing plans. While medical error mistake can be defined as an event that is preventable with the current state of medical knowledge. So when we think about perio or complication, we are focused mainly on the act of surgery, so of technical errors. However, surgery is only a very small part, a small piece of a bigger picture that we can call therapeutic process, in which we have two different phases. The first one is the pre-surgical phase, in which we have to examine the patient, the medical history, diagnose, make a prognosis, and formulate a treatment plan. And we have a post-surgical phase in which we have to work hard together with patient to maintain the achieved results and to avoid the occurrence of or recurrence of that specific condition. And in all of these cases, we can have these famous issues. And specifically, in the pre-surgical phase, we can have mainly medical errors, let's say, in the surgery. So in the surgical phase, we can have both of them, medical errors and complication, and in the post-surgical phase, mainly complications. So just to be didactical, I divided the presentation in these three phases. So let's start from the pre-surgical one, in which we have these different steps that are very important, very crucial in order to make the remaining part of the process very easy and very flawless. And in this phase, as I said, we can have mainly medical errors that are due to lack of knowledge of clinicians. So we need a very strong background in order to detect all the weakness, all the issues that we can have during our therapeutic process. And since we have to deal with human beings beyond gingival sessions, of course, we have to evaluate systemic diseases, especially diseases that may affect the healing of connective tissue. For instance, diabetes, especially if uncontrolled, or all those systemic diseases that might affect the act of surgery and the postoperative period. So I'm talking about coagulopathies and the intake of some kind of medication, such as anticoagulants and biphosphonate, especially. We have other issues that I reported here. We have to evaluate also oral factors, so local factors, because from one side we have poor oral hygiene and inflammation that may determine the plaque-induced gingival recession. But on the other side, we have high oral standard of hygiene. So some issues correlated to toothbrushing, the excessive forces, the wrong bristle, and etc. And both of these two factors, local factors, may affect the results and the maintenance over the time of the achieved results in terms of root coverage in this situation. Surely, smoking always affects treatments in general, and in particular, we have to know that smokers, even the evidence is limited, may benefit from periodontal plastic surgery. However, we should know, and patients should know, that they have less mean and complete percentage of root coverage compared to non-smokers. So this is very important for patients to be aware of. And one important factor that I would like to point out in this pre-surgical phase is something new in dentistry, let's say, but is more investigated in other branches of medicine, such as orthopedics or plastic surgery, and is the intake of dietary and herbal supplements. For us, it's something new and it is spreading a little bit. However, in others, in these branches of medicine is quite investigated, because we have some evidence that the intake of this kind of products influence the impact, the incidence of bleeding during and after surgery. And this is something that may affect negatively the result, especially for our colleagues of plastic surgery. We know that
maybe this could act as a hidden confounding factor that we don't know about.
Yeah.
Usually we don't ask about supplements, we just ask about the medical history and the big issues, and maybe these are hidden stuff.
Exactly, this is the point. Yeah. We know that the bleeding process is a balance process in which we have coagulation, fibrinolysis, and anticoagulation that works together. So there are several molecules that might be the target of the ingredients included in these supplements that act mimicking anticoagulant medications. So the results, the mechanism of which they work may be antiplatelet, anticoagulant, as you can see here, both of them, or other mechanisms such as the interference with the vitamin K production. Mm-hmm. All these mechanisms of this product results in this final outcome that is an uncontrolled bleeding during and after surgery. Mm-hmm. So just to give you an idea regarding the market, the Italian market of this product in 2017, as you can see, about 80% of patients intake these supplements to enrich their diet. Mm. And the weak point, as you pointed out, is that these products are over the counter, meaning they are out of control in terms of medical prescription. They can be bought in by a patient without any kind of prescription. Mm-hmm. And this means that 8 out of 10 of our patients intake this medication in our dental office in Italy. So this is a very high percentage. And we can borrow some recommendation from the American Society of Plastic Surgery. First of all, as clinicians, so as dentists, as periodontists, we should be more aware regarding this product, regarding the supplements and the ingredients included. Especially, we should be more informed regarding side effects, of course, and make patients more aware regarding side effects, because patients think that since these products include herbs, so let's say natural products, they think that they are safe without any kind of side effect, but it's not true, for sure. Mm-hmm. The other important aspect is that we need to review this product as we do usually with medication and record them in the medical file of patients. And the end, the suggestion of plastic surgeons is to stop the intake from 2 weeks before surgery until 1 week post-operatively. This is the indication for all these products, because since the ingredients, so the label are not so precise, and we cannot know, we do not know exactly the percentage of each ingredient. The suggestion is quite general, let's say. So if you know that patient intake this kind of medication, supplements, you stop the intake.
Mm. And it shouldn't be a big problem because they are supplements. They are, stopping them will not cause a huge problem for the patient.
Yes, absolutely. It's not like medication, anticoagulants. So yes, absolutely. Mm-hmm. After having evaluated patient medical history, we have to diagnose our gingival condition, and in this case, our gingival recession. And usually we know we have this idea of gingival recession associated with a long tooth, okay? Mm-hmm. However, in order to diagnose a gingival recession, according to the definition, we need 2 key factors. The first one is that we should see the CJ. So CJ should be visible and identifiable. And the second one is the exposure of the root, okay? So let's see together this case in which we have this long tooth, the 21, and trying to detect a kind of CJ, we cannot see it because it's covered by the gingival margin that is located 1 millimeter beyond the CJ. So in this case, the problem is the adjacent tooth that is affected by altered passive eruption and usually clinically appears as a shorter tooth. I know that for you, experienced clinicians might be banal, but it's very, very important for the just graduate or less experienced in order to not confuse situation of long tooth with gingival recession, because we need to identify specific anatomical key factors to make a proper diagnosis.
Of course.
And after diagnosis, we have prognosis. Prognosis, we have to put our gingival recession in a classification. And this is the last World Workshop in Perio, in which a new modern classification has been proposed, Cairo 2011, in which we have 3 types, type 1, type 2, and type 3, according to the amount of the interdental clinical attachment loss. And we have also an idea regarding the amount of root coverage that we can achieve for each class, okay? Mm-hmm. And the most important novelty in this World Workshop is this article, paper published by Cortellina and Bissada, in which we have this tool that, in my opinion, is huge. It's very useful because at first sight, filling this table, you can have immediately the treatment of your gingival recession. And I would like to point out the importance, they would like to point the importance, and me as well, the importance of hard tissue beyond soft tissue. So nowadays, when we look at the gingival recession, we have to consider the CJ and the presence or the absence of the cervical step. Why this is so important? Because CJ represents our reference point for the measurement of gingival recession, the measurement of the amount of root coverage achieved. And it represents also our reference point over which we can position the connective tissue graft if used, and the final position of the coronal advance flap in this situation. So it is very, very important to identify and eventually to reshape a CJ when it is missed. And in fact, we have some clinical anatomical condition that do not allow to achieve the complete root coverage. So we have some cases in recession type 2, recession type 3. We have anatomical conditions in which we have interdental soft tissue loss. We have extrusion, we have rotation. All these condition determines an altered position of the anatomical CJ. And thanks to a measurements introduced in this paper that I'm sure you know perfectly, we can, according to the ideal dimension of papilla, interdental papilla, reshape a CJ, a new CJ called clinical CJ, and reaching the maximum root coverage. And this new CJ can be rebuilt, reshaped, thanks to a composite restoration that we can perform 1 week or 10 days before the surgery under using a rubber dam when possible, in order to have a perfect isolation of the field for the adhesion. And in this way, we are able to trick a little bit the biology. So all those conditions in which we cannot achieve the complete root coverage, we can trick a little bit, reshaping the clinical CJ. As you can see, in fact, in this case, we have interdental soft tissue loss, which doesn't allow a complete root coverage. Therefore, we have to reshape more apically the clinical CJ using a restoration, and now we are able to move the tissue coronally, using with or without connective tissue graft as you wish. And this is true also for non-carious cervical lesion, because sometimes non-carious cervical lesion may represent 0.5% of the problem, as you can see here. So without the treatment of this non-carious cervical lesion, we have for sure a failure of our final treatment. Because if we do not treat the non-carious cervical lesion, we for sure end up in a situation like this, in which we have the advancement of the flap and the use also of connective tissue graft. As you can see here, we have a quite huge thickness, and between the crown and the connective tissue graft, the soft tissues, we have a very, very deep step that is a weak point for oral hygiene for patient, because this area is very, very difficult to be maintained by patient, becoming an area in which we can have plaque accumulation, inflammation, and furtherly even a periodontal pocket at the buccal aspect. So it is very, very important, in order to not incur in medical errors like this, to evaluate carefully all this situation before, so during the post-surgical phase.
May I interrupt with a question, or would you like to leave it to the end?
Maybe at the end.
Okay.
Okay.
Yes.
So now maybe we move into the surgical, so technical aspect, in which we can have several issues that I would like to show you in details, and they can be defined in both ways. So as the errors, as a complication, and of course, when we commit an error, it's up to us. So it depends on our lack of knowledge, also lack of skills, because sometimes we are not able to perform this kind of surgery, but we do it anyway, and of course we end up with some issues or some failures.
Mhm.
So let's start from that so-called excessive bleeding. What does it mean, excessive bleeding? We have in literature some studies in which the amount of blood loss has been measured, okay, in periodontal surgery. And the authors found out that the blood loss during periodontal surgery is very minimal, because it ranged between 6 millimeters up to 145 millimeters, compared to, for instance, orthodontic surgery, in which we have a blood loss of 600 millimeters, is very minimal. Okay, so we cannot talk about excessive bleeding in periodontal surgery. But I would like just to remind you, the intake of anti-inflammatory steroidal drugs may influence the bleeding during the surgery. And for this reason, despite in several randomized clinical trials, you can read that there was an administration of these drugs before, I suggest to administer this kind of drugs immediately after the surgery, so in order to not influence negatively the amount of bleeding, okay?
Mhm.
But we can commit a mistake and we can have an excessive bleeding when we perform the coronary advance flap and we do not perform adequately the split thickness. You know perfectly that the coronary advance flap advancement is reached thanks to split incision. We have the deep one, in which the blade is kept parallel to the bone, detaching muscles and flap. And we have the superficial one that is done thanks to the blade parallel to the lining mucosa, detaching the muscles from the inner aspect of the flap. So we have a kind of two planes, okay, staying parallel to the bone and staying parallel to the superficial mucosa. If you keep the blade in the middle, let's say, so in the submucosal area in which we have fatty glandular tissue and greater vessels, it might be that you can incur in an excessive bleeding because you are damaging greater vessels. And this is our suggestion to perform adequately, maintaining the blade parallel to the bone and parallel to the lining mucosa in order to not damage this area. Furthermore, it is as the technique taught us, we have to perform this split thickness immediately after flap elevation and protecting the flap with a gauze in order to reach the final part of the surgery, meaning the sutures part, with a very great visibility and bleeding control.
Mhm.
Oh, sorry. When we go on the palatal aspect, we have to be a little bit more concerned because we have an important structure that is the greater palatine artery, that is a very, very important structure that we should know carefully, and especially during the harvesting procedure. Of course, we should know the course and the emergency. And thanks to this systematic review published recently by Lorenzo Tavelli, we have also a sort of safety, that so-called safety zone, that is that we can measure 2 millimeters from the gingival margin at the level of the palatal aspect, and it ranges from 5 millimeters up to 11, more or less, at the level of the second molar. Staying, harvesting a graft in this area, it could be considered safe because we are far away from the course of the greater palatine artery.
Mm.
We have, as you know, several techniques to harvest the graft from the palate, and I would like to show you these pictures and these drawings in which you can appreciate the fact that in all these three techniques, the surgical area is always bigger than the dimension of the graft that we need. Okay, so in all these cases, we have to evaluate carefully the thickness of the palate and also the shape of the palatal vault in order to choose the right technique. And this is the reason why we prefer to use our technique proposed in 2010, this depitalized gingival graft. That is a very easy technique that you can use for single or multiple defects, that you can use whatever is the thickness of the palate and whatever is the shape of the palatal vault. Of course, if you use it as a subepithelial connective tissue graft, you have to depitalize extraorally with a blade.
Mm-hmm.
And we have tested this technique in 2 our papers that you know perfectly.
You do.
In which we have evaluated the graft, harvest with trapdoor technique and depitalized gingival graft, and we found out that the morbidity, the patient morbidity, is more or less the same. Okay, the importance is correlated with the thickness of the palatal withdrawal, let's say. So if you have more than 2 millimeters of palatal thickness to leave to cover the palatal bone, you can use the trapdoor technique. Otherwise, we highly recommend to use the epithelialized gingival graft that you can use always, basically. Okay.
Yes.
And the same technique has been used to test different size of grafts. So the epithelialized gingival graft, but with the big graft and the smaller graft. And for smaller, I mean a graft height 4 millimeters, standard height of 4 millimeter, and the thickness less than 1 millimeter. And the result was very interesting because looking in the pursuing of reducing the morbidity of patient, this technique works very well, since we have the same percentage of root coverage, we have less morbidity, of course, and we have better aesthetic outcomes, since the graft is smaller and thinner for both professionals and from patients.
Yes.
And yes. Okay. And this technique has been also evaluated in this systematic review, reporting higher, not so higher, but a quite important difference using coronal advanced flap plus the epithelialized gingival graft compared to subepithelial connective tissue graft. So one more confirmation of the suitability of this technique. And just to see a little bit of surgical movies, I am sharing with you these 2 brief videos in which you can see the technique that we can use for single or multiple defects, starting with an horizontal incision, 1-2 millimeters far away from the gingival margin of the palatal aspect. We can do 2 vertical releasing incisions, mesial and distal. We start with the blade firstly sharp in order to reach an adequate thickness, 1 millimeter. Then we can go parallel to the palatal mucosa in order to calibrate the graft and to make it homogeneous from one vertical releasing incision to the other. Once we are sure about our thickness and about our dimension, we can harvest using a second horizontal incision located apically. As you can see, the bleeding is easily controlled, and we can use, we usually use a sponge, collagen fibrin, and a double vertical matrix suture, cross suture, to stop the bleeding that is coming from the palatal side, so the knot is always closed at the level of the distal apical aspect. Now, an interesting, I think, topic, perforation. Perforation that is for sure an error, a technical error, and we can define perforation as an interruption of the integrity of the soft tissue. So it's an opening, basically, okay? And during root coverage procedure, we can do this kind of error when we tunnelize, as you can see in this case, the peripheral area using an envelope flap, because we are not so superficial, we are not so parallel with our blade, as you can see here in this video. But as the perforation in these two cases, in this case, these two perforations are so small, so as you can see, no sutures were done and the healing was perfect. But sometimes we can have bigger perforation, and this could happen when we are performing the superficial incision. So always try to keep the blade attached and parallel superficially, but we can end up like this, as you can see. And since the perforation is quite big, more than 2 millimeters, and lies on the avascular root of these central incisors, we decided to change our plan, because otherwise we wouldn't have added a connective tissue graft at the level of the central incisor, because as you can see, we have enough keratinized tissue to cover the root. So one more connective tissue graft has been added here, and furtherly, we have also closed the perforation using the key point of perforation, of the resolution of perforation, is to use very small needle, 7.8 millimeter, and very thin thread, 7.0. And as you can see, despite the perforation, the healing was very pleasant. One more case, very interesting, because in this area, that is a maxillary area, we have some, of course, some anatomical issues, because we have reduced visibility. We have a very strong muscle insertion, and for this movie, also the presence of this dip retractor. So we have performed, during the performance of the superficial split thickness, as you can see here, we have made a huge perforation. Now you can see it better, yes. Okay? So at this point, we have to go further, of course, we cannot go back. So it is important to what? To reach your advancement, your core advancement. And we need, in this case, to overcome the perforation using a small elevator firstly. Then we can go back with the blade and go further apically with respect to the perforation in order to reach the final advancement. As you can see, during the movement, the perforation was enlarging. So in this case, the sutures should be done now, because otherwise we can end up with a complete interruption of the distal part of the flap. And at this moment, we can close a little bit with 2 or 3 sutures, the border of the perforation, just to keep the perforation together, let's say, always using very small suture, 7.08 millimeter. And once you have completed the marginal and the vertical releasing incision sutures, you can go back to your perforation and do more sutures if needed, because you have to check them, you have to check the perforation at the end, okay? So let's see the healing. In this case, we have used a higher connective tissue graft in order to compensate the perforation that has been done at that level. And as you can see, the healing at 6 months was very great. So despite this huge perforation that has been done, so it is important to know how to manage them. Of course, we do not have always, we cannot use always the same rule, because it depends on the dimension, on the extension, and on the location. One more cases of perforation that I'm sure you will appreciate. That is the treatment of this mandibular incisor. And you know that mandibular incisor are a sort of nightmare for periodontists, because sometimes we have very difficult anatomical factors that represent an obstacle for us. So we have shallow vestibule, very strong lip muscle insertion, thin mucosa, no keratinized tissue, and using a chronically advanced flap, we have to create a brand new flap directly from the mucosa of the lip, as you know perfectly the technique, right? And sometimes managing this very thin tissue, we can end up, as you can see here, with this huge perforation exactly in the middle of the flap. Of course, even in this case, we need to go on and to reach the mobility. Otherwise, we cannot send patient at home with this kind of flap. So we use, in this case, the plan was already included a graft, so we didn't change our plans. We started from one vertical releasing incision. Remember that it is important to perform the sutures with a reverse sequence. So starting from the sling suture, then we can suture the periosteal vertical releasing incision in a more comfortable way. So in this case, we treated firstly one vertical releasing incision, and then we tried to close the perforation, as you can see here, because it is very, very close to the marginal aspect, this marginal, thin, delicate, traumatized tissue. So we need to be very gentle during the sutures, and only using small sutures we are able to manage situation like this. Otherwise, we cannot use a 5.0. Okay, so yes, tell me.
No, this one is tricky.
Yeah. Once you have completed the vertical releasing incision, as earlier, you can go back to your perforation and close perfectly all the borders. It is important to not engage the connective tissue graft as well during perforation sutures, okay? So just the flap. So as you can see, I don't know if it was luck or what else, but the healing was incredibly perfect even at 14 days. That is the third pictures, and this is the result at 1 year, in which we have a perfect complete root coverage, soft tissue integration, thickness, maturation. So once again, the importance of an adequate management of the complication. Just as I said before, just to give you some rules according to clinical experience, because that's it, clinical experience. So no suturing when the perforation is very small and located in a vascular area. So when we are on a periosteum or in between interdental area, but if it lies on a avascular area, so on the root surface, we have to treat it. We have to suture it when the perforation is bigger, so 2 millimeters, but lying on vascular area. and the connective tissue graft should be added despite the dimension, so independently from the dimension, when we are when the perforation is located on the root surface. So this is very, very important to remember. Otherwise, we can end up with a fenestration or a gingival session in that area. Okay. Now I would like to discuss also this another aspect, because of course when we treat the buccal aspect we have to deal with two nerve injuries, with two nerves, and I'm talking about the infraorbital nerve and the mental nerve. Regarding the infraorbital nerve, fortunately, I've never faced any kind of issues, because the infraorbital nerve is located very, very apical compared to the area that we are treating. Especially because when you treat the maxillary area, the amount of the deep dissection that you usually perform is very small, because as soon as you can keep the blade parallel and superficial, you go superficial. And once you are superficial, you are far away from the emergence of the nerve that is located at the level of the under the dichomatic bone and very, very high. So I've heard some colleagues that faced this kind of issue, but I think because the deep dissection was made wrongly. Okay.
Was it in a root coverage procedure?
Yeah.
Wow.
So I think the mistake was to perform a very deep dissection. So go very apically. That is not necessary at all.
Yes.
The other important, no, sorry, not this one, this one. Okay. The other structure that might represent a concern for us is for sure the mental nerve. So the mental nerve, when we have to treat this area, for sure we have to do an X-ray before. An X-ray and orthopantomography as you wish, but just to have an idea regarding the emergence of the mental nerve. Okay. So in the mental, in this area, we do not perform the deep dissection. So we do not keep the blade parallel to the bone, attached to the bone, because otherwise the risk is very high. Therefore, what we can do, we can substitute the deep dissection with the gauze technique. So 2 fingers, a gauze, we gently push towards the apical area the flap that is positioned closed, let's say. And as you can see here, we can see perfectly the relaxing of the fiber muscles using this technique. And looking inside, and thanks to the use of tweezers, we can pull gently the flap, and we can separate these fibers inserted into the inner aspect of the flap, one by one, let's say, in order to move, to perform the superficial incision, because the deep dissection, it is necessary just to perform the superficial one, okay? So as soon as you are able to see this relaxing structure, you can go with the blade. It is important, as you can see here, all this area should not, that is the submucosal area, should not be touched by the blade, because here, according to the emergence of the nerve, we have the nerve, okay? And using this technique, so the combination of gauze and the spray thickness, we are able to reach a perfect advancement of the flap, as you can see here, without any kind of problem.
So it's much like we are cutting more buccal to the nerve, like above the nerve.
Yeah, absolutely, yes, because the emergence is located very close to the bone. So if we stay very superficial, so very external, no risk at all to damage the nerve.
Yes.
But I would like to recommend you to have an X-ray for sure, also for medical legal point of view.
Yes.
And at the end of the surgical phase, I would like to point out the surgical stability. You know that the final phase of the surgery is the stabilization of the flap at the level of the vertical raising incision if performed, and at the level of the marginal aspect. And you know that using coronal advanced flap, we have the sling suture suspended around the palatal or lingual cingulum that allows the perfect adaptation of the surgical papilla above the anatomical papilla, and it allows also the perfect adaptation of the gingival margin above the convexity of the crown. And this adaptation should be very tight. So at the end of the surgery, we should not see any kind of oozing of bleeding from this site. Otherwise, something went wrong and we have to do one or more sutures in order to reach this surgical stability that is crucial for the early phase of healing.
Mm-hmm.
Okay, now we can talk about the post-surgical phase that is very, very rich and full of issues, starting from the most frequent up to the less frequent, and that we are going to see in details all of them. I would like to underline also the importance of giving post-operative instruction, even at the initial phase. So when you propose a treatment plan, I think that is important and could be very appreciated from patients to give all the postoperative instruction in order to make them aware regarding to this kind of issues that might occur, because some of them are let's say physiological, okay, after a surgery.
Mm-hmm.
Okay, just a sip of water.
Sure, take your time.
Okay. We know that pain, swelling, as I said, is quite normal and easily controlled thanks to anti-inflammatory drugs, painkiller, swelling by means ice packing for 6-8 hours after surgery. And just to remind you, according to the literature, that pain is strictly correlated to these three factors: the duration of the surgery. So the longer the surgery, the greater is the pain perceived by patient. And a recent study by May, published in 2016, reported that a threshold of 60 minutes seems to be the time that may differentiate from mild up to severe pain perceived by patient. Smoking, for sure, is something that patients should avoid during the postoperative phase because it influences vascularization and make the healing more painful. And it seems also that surgeon experience may represent an issue. But I mean surgeon experience in terms of manipulation of the tissue. So the less we traumatize the tissue, the better is healing.
Mm-hmm.
We can have hematoma, and hematoma or bruises that are usually associated with surgery in which the flap are releasing. So of course with coronally advanced flap. We can have extensive hematoma, as you can see on the left side, or very localized hematoma, only the buccal aspect. It's not a painful situation. So, but it is important to inform patients because it might represent an aesthetic concern, especially for all those patients that maybe do a job in which aesthetic is important. I don't know, actors or even people who work with public relations. So it is important. This information before.
Mm-hmm.
We can have also early bleeding at the primary site. That is something not so common, and it at the level of the primary site, so at the level of the flap, because, and it seems that it range between from blood, things, saliva, up to an aggressive oozing, or up to this manifestation that is quite scaring, that is called liver or current jelly clot, that is resulting from a venous hemorrhage that is usually slower in terms of flow, and it is darker in the color. This is a very easy actually situation to manage, just the manifestation could be scary for patients. So first of all, we have to reassure patient. Secondly, we have to understand why this happened. And we have to interview patient regarding traumatic causes, such as chewing, tongue forces, or pulling of the muscles of the lip to look at the wound, or maybe some premature loss of sutures. So how we can manage this situation? With the gauze, we remove gently the clot that can be localized or extensive, as you can see on the right. We remove gently the clot. Then we check the interdental sutures. So if sutures are have been lost, we have to do them again, okay, in order to reach that so famous surgical stability. And it is important also to remotivate patient in terms of postoperative instruction in case the causes was a traumatic episode, and to discharge patient only when the bleeding is perfectly controlled. We can also apply some pressure using gauze soaked with hemostatic agents. It's not mandatory, but we can make some pressure if we have a lot of oozing or bleeding from the marginal aspect. The same bleeding can be present also at the level of the donor site, that can be managed in the same way. In this case, we can have also some traumatic episodes that may be the cause of this situation, or because we have harvested a graft very deeply. So we have damaged some greater vessels during our harvesting procedure. In the same way, we can compress using a gauze soaked with hemostatic agent, or if needed, we can do some sutures, some crossed compressive suture in order to block the bleeding. At the level of the palatal site, we can have also this situation, the necrosis of the palatal flap, especially when we perform the trapdoor technique. And as I said before, the trapdoor technique should be performed when we have an adequate thickness, so at least 2 millimeters left to cover the bone. However, even in the presence of this situation, we can have this kind of healing. And the explanation might be some chemical or traumatic injuries that may occur during the postoperative healing. So sometimes not depends on our only at our treatment, but might be a complication that may occur during the healing phase. And now I think a very interesting aspect that we have to face now, that is the flap dehiscence. The flap dehiscence represent, let's say, an opening, a shrinkage of the flap during the first postoperative healing. So let's say during the first 2 weeks. And this occurrence of course, might determine a failure of the treatment, because we can have, again, root exposure and also the exposure of a graft if it has been used. What we can do in these cases, very, very bad cases, we have to wait. firstly, we have to wait because biology should do its course. And as you can see here, after 3 months, only 3 months, we have a beautiful recontouring of soft tissue. We have almost about 100% of root coverage despite this complication. And we have perfect soft tissue integration. So in this case, despite the flap dehiscence, we reached a beautiful result, okay? Mm-hmm. But sometimes we can end up, even of some months of waiting, we can end up with the same situation. So in this case, for sure, we need to do a new surgery to solve the problem, starting from analyzing what was the problem and what was the issue, what was the mistake or the bad behavior of patient. Mm-hmm. And about, yes.
About the kind of modification you're going to do here. I mean, are you going to split all over again and coronally position all over again? Like it's a new surgery?
Yeah, exactly. And put a new connective tissue graft because you have to evaluate the thickness of this, the remaining flap, if it is adequate or not, and put a new connective tissue graft, yes.
Mm-hmm. Okay.
So in particular anatomical area, we can manage and reduce the incidence of flap dehiscence, managing the submucosal tissue, especially in the mandibular incisor area. So from lateral to lateral, only in this part, we can perform this kind of removal in order to, and we performed a randomized clinical trial to evaluate this. And as you can see, the number, we reached a complete root coverage in 88% of the teeth in which the submucosal tissue was performed, reducing therefore the flap dehiscence, improving the root coverage, and reducing also the graft exposure. Furthermore, the morbidity in patients in which the submucosal tissue has been removed was exactly the same. Exactly the same where compared to patients of the control group. So in this area, in the mandibular incisor area, in which the muscle, the lip tension, the chin tension, and might represent an obstacle for healing, especially in the first days. This kind of surgical tip can be very useful in order to retard the early insertion of muscles. And about the flap dehiscence, this is a very funny, not so funny video of a colleague of mine in which you can see how patient might represent sometimes the biggest complication, because even if you have performed everything perfectly, patient, thanks to the pull tension, might determine an early destabilization of the flap in the first hours of healing. So it is very, very important to, let's say, also scare patients regarding the impact of their behavior on this kind of treatment. And just a funny video to share with you how patients behave usually. Furthermore, regarding flap dehiscence, we can have them also at the level of the maxillary area, because as you can see here, we have a case in which some surgical aspects have not been correctly performed. You can see in the posterior area, we have some flap tension, residual flap tension. We have a quite huge perforation. And I would like to underline the bad adaptation that we have at the level of the interdental area, in which we should have a very great adaptation between surgical papilla and anatomical papilla after this epithelialization. And this is the healing after 2 weeks. Not so good, as you can see here. And despite the waiting time, we have 6 months, we have reached this unpleasant, let's say, unpleasant result. So just to underline how papilla desepithelialization should be performed, that is a very important moment, because this area represents the connectival bed of our surgical papilla, and represent the blood supply for the survival of the marginal flap. So it is important to perform the desepithelialization adequately, using firstly a blade parallel, and then in order to reach the most coronal layers of epithelium under the contact point, the microsurgical scissors. And only doing perfectly this phase, we are able to interface two connectival beds, because bed adaptation is not only sutures, bed sutures, but also leaving some epithelium layers at the level of the anatomical papilla. So just to summarize some causes of flap dehiscence according to the literature, we can have a no adequate flap mobilization, marginal stability, inadequate marginal stability, so some bleeding, some oozing from the marginal aspect. We can have, if we do not manage adequately some areas of the oral cavity, early flap dehiscence. The position of the post-surgical margin, you know, that influence a lot the stability of the flap, and the inadequate papilla desepithelialization that should be done according to the technique that has been proposed. And correlated with flap dehiscence, we have graft exposure, because when we use connective tissue graft plus coronal advanced flap, of course, if we have flap dehiscence, we have the graft exposure that ends up like this, like a double scalloped line, sometimes whiter soft tissue appearance, or sometimes even with a similar keloid aspect appearance, as you can see here. And from the literature nowadays, we know that root coverage, so complete root coverage, is the only aspect that we have evaluate to score our successful treatment in terms of gingival recession. In fact, there is root aesthetic score proposed by Cairo underlined this topic very well, because he introduced 5 aspects for more than the root coverage. And I would like also to remind that also patients are very aware regarding other aspects, because we have a study published by Kim 2014, in which they compared the score between patients and professionals, and they found out that patients scored better soft tissue integration and color match compared to root coverage. So it is very, very important. And correlated to graft exposure, some aspect that should be taken into account in order to avoid or reduce this kind of occurrence. So the position of the graft, for sure, they should be positioned at the level of the CJ, not coronally, because if it is coronally, it may determine the flap shrinkage and the graft exposure. The graft dimension that we have showed, smaller and thinner dimension, are correlated with better aesthetic results from patient and professional. Even in this case, managing the submucosal tissue removal may determine less graft exposure, and for sure the post-surgical position of the gingival margin that should be located 1 millimeter beyond the connective tissue graft. Now we are going towards the final part of this presentation, in which I grouped the rarest complications, starting from root resorption. we know that root resorption is an undesirable pattern of healing that may occur when we elevate a flap, a mucoperiosteal flap, and we have a denuded root surface. But fortunately, this is infrequent because we have the mechanism barrier of epithelium, long junctional epithelium, and the cell coming from the periodontal ligament. However, after root coverage procedures, it has been shown that root resorption may occur. We have several studies reported in the literature, and using coronal advanced flap plus connective tissue graft, free gingival graft, coronal advanced flap plus subepithelial connective tissue graft. So with several techniques, we can end up with this kind of root resorption. And the treatment proposed in the literature ranges from surgical restorative approach up to the extraction. It depends on the extension, on how the tooth is compromised. What is very important is the early diagnosis, because the earlier the diagnosis is, the better is the prognosis. So this to say that it's important to put patients, mucogingival patients, under maintenance care in order to detect this kind of occurrence early. And in this way, we are able to keep the tooth and to solve the problem, as I'm going to show you in this case. In our clinical experience in our department, in the last years, let's say in the last 7-8 years, we have faced more or less 10 cases like this. Okay, wow. 10 cases, not so, it's quite enough, I think. But we have managed them beautifully and successfully because of the early detection of this situation. So this is a case of calf plus connective tissue graft, in which after some years, I think 3 or 4 years, I don't remember, we have this kind of appearance at the level of the cervical area. This is without any kind of symptom from patient point of view. The tooth was vital, and we performed an X-ray showing this kind of, you can see the transparent area in the X-ray, okay, that is irregularly shaped. So we have decided to try this surgical restorative approach proposed in the literature. So we have elevated a flap, clean the lesion. As you can see, this is an irregular lesion, and we have put a rubber dam in order to isolate the field. The use of a liner, as you can see here, depends on the depth of this lesion, so it is for the protection of the pulp, and we have used a flowable composite. The most important aspect of this technique is to smooth as much as possible the root surface, the composite surface, because we need to create a very, very smooth and very clean surface over which the connective tissue graft, the connective tissue of our flap could attach, could heal, okay? And we came up with the very beautiful results after 3 months, one year. And we have this kind of stability. Now it's even more, because this is, I think, last year. So now we can have 6 years of follow-up. As you can see, we have the stability of the lesion. We did not lose the vitality of the tooth. Of course, we can improve, let's say, the color of this area because it's a little bit darker, but the most important thing is to keep the tooth and to maintain the periodontal healthy conditions. One more rare condition. I've never faced this kind, and in fact you can see that I've reported some of pictures that I found in the papers reported in the literature, and this is the extosis appearance after free gingival graft that may appear over the years as a bone growth that could represent at the beginning no type of discomfort patient, but with growing it could represent a very important issue. And from our point of view, despite the discomfort of patient, is to make a differential diagnosis from a malignant tumor, bone tumor, that may appear in this way. So we have to perform a biopsy in order to understand the histology of this kind of occurrence. And if it is fortunately a malignant tumor, we have to send it to the oral surgeon for complete removal. Mm-hmm. And finally, an important aspect, because we are dealing a lot with connective tissue grafts, so we need to know also this kind of occurrence. And this is the cyst-like area appearance that could actually ends up like this, so with a cyst-like area, but it could start also like a very small fistula, a similar fistula from which we can see the emergence of a very thick and dense white material that is not pus, but is represented by let's say a kind of epithelium exudate, exudation of this kind of material. In fact, the histology reported in these studies reported the presence of island epithelial cells left after the depithelialization or the use of subepithelial connective tissue graft. So I would like to recommend careful depithelialization, and just to give you an idea of how difficult is this depithelialization. This is an histological study with a very small sample size, five samples, but it's very I think challenging, because despite the ideal condition, so microscope, light, and the authors found out that there's still a percentage of epithelium layers present in the connective tissue graft after this epithelialization. So it is very important to do it, to perform it carefully. And just to remind you how we should do this, with a new blade, very magnification and a good light, and we can start from the inner aspect, removing petting glandular tissue, and then we can go on the epithelium site, removing it perfectly, and starting with a little bit of beveled inclination, and then go parallel to the superficial layers. Pay attention to the depithelialization of the borders, performing also the vertical depithelialization. Mm-hmm. So let me conclude reminding that the combination of the correct evaluation of the patient together with the theoretical knowledge and skills are the key elements to achieve successful results, even in presence of complication, that clinicians should be able to manage. And furthermore, the information of patients regarding the expected complications play a fundamental role in terms of doctor-patient relationship and start. So thanks for your kind attention.
Thank you so much, really, for such an effort and for such an informative presentation. This was really very nice and very informative, and we also knew some new information for us about complications today. So thank you, really. And you can tell me how much time do we have for questions?
10 minutes, it's okay?
Okay, yes, more than fine, yes.
Okay. So this is our group that you know already.
Yes, of course. As I told you, we are a huge fan.
Yeah, I stopped sharing the screen, okay?
Yes, I did it already. Okay, so first, let's start with some questions about the complications. We have got two questions here, I guess. Guito were asking about the perforation in the lower cases. When you sutured the flap, do you suture the flap with the connective tissue? Would you advise suturing the flap with the connective tissue?
No, absolutely not. We suture firstly the connective tissue graft, then we started with the flap, trying to not engage the connective tissue graft when we are suturing the perforation.
But as you explained, we only use the connective tissue graft if the perforation is above an avascular bed. It's a kind of protection and blood supply for the perforated area.
Yeah.
Yes.
But if you have already planned to perform a connective tissue graft, you put it. So your initial plan will change only if it doesn't include a connective tissue graft.
Yes.
So okay.
In the original design, yes.
Yeah.
Yes, of course. So let me ask you about some of the complications. This was nearly the first time I hear of resorption occurring with root coverage procedures.
Oh, really?
Yeah. Why do you think this could happen? What's the explanation of this?
We know from classical studies that histological classical studies that sometimes the healing may be bothered by some factors, and therefore the speed, let's say, of healing might be compromised, and in this way we do not have the protection of the epithelium cells or the ligament, and we have the interference of connective tissue cells that are the first to colonize the root surface. This is the reason why, from a histological point of view, why this happened. Actually, we do not know, because this is something that we are not able to explain. But we know for sure that this is something quite unlikely.
But we have to, I think we have to follow the patient complaint, because maybe it starts with some sensitivity. So we shouldn't take this for granted. If he starts to complain of sensitivity all of a sudden, maybe you have to investigate if there is a start of resorption or something. And is it always external?
Yes, but sometimes it could happen even in the middle part of the root, in the mid further, not always at the level of the cervical area. So if it is at the level of cervical area, it's easy to be diagnosed by us or by patient. But in the middle, in the mid third or in the apical third, it's more complicated.
Yes.
Of course, if you have the root resorption at the level of the apical area, you have to evaluate accurately what to do, because it's not the same compared to the cervical area. But we do not know a lot regarding this. This is why I think when you can keep the tooth and trying this restorative approach, it's a good idea. It's a good choice for our patients, because as long as you can keep the tooth, it's better, especially in young patients or in the anterior area.
And after doing the surgery, actually, after going through the surgery. So yeah, definitely. Okay. Also, I wanted to ask you, have you ever faced this cystic formation? Because we only read about it, but I've never seen it. Have you ever faced
once, and it solves spontaneously, because let's say that is a kind of a sudation that we have in the area, and the manifestation is this kind of fistula, and the emergence of this thick material, but it solves spontaneously, so you don't need to do a lot. At least in my experience, I've seen only small situation, non-cyst cyst formation or bigger cyst formation.
Yes. Okay, how about this? Yes, okay. How about this ossification that you described? Because I have faced this once around 10 years ago, and I had a patient with multiple recessions, and we did the graft, and after around 3 months from the surgery, post-operatively, she reported that she has like a bony exostosis growth.
Yeah.
And she was very annoyed by it, and we had to remove it with a chisel. So have you ever faced this?
No, the exostosis never. Never. In fact, I reported the papers, pictures. The explanation, according to authors, it might be an excessive reaction of periosteal cells in this area, determining a bone growth. But it's not a huge problem because you can manage it somehow. And if it is annoying, bothering the patient, you have to remove it. Just remember that it could be also another aspect. We have to detect if it is something else. So it is important to make differential diagnosis with malignant tumor. This is the most important aspect, I think.
Okay, and how about the bleeding of the palate as a complication? Have you ever had to suture the greater palatine artery or take a ligation suture?
Never, because if you cut the greater palatine artery very close to the emergence, this artery retracts, so you have to call the ambulance. So this is something that performing the harvesting procedure that I've show you, so the epithelialized gingival graft never happened. Never.
Yes.
It might be that you can, if you go deep with the harvesting procedures in terms of palatal buccal direction, you can damage some greater vessels, but you can control it using some bigger sutures. Okay, so this is not a huge problem. But of course, if you perform other kind of technique as the single incision, and you need a very big graft, and you need to go to be more extensive, as I showed you, it might happen in this case. But you have to evaluate carefully this before.
Of course, yes. So I've heard you explaining that sometimes with the lower recessions, with the mandibular recessions, you have to use a bigger graft epicocoronally, more than 4 millimeters, according to the vestibular depth.
Yes, this is something that we have tried in the last years, and that we are publishing in very soon, because using a height that is comparable to the adjacent height, vestibule height, that allows to recreate that kind of vestibule depth that we need in this kind of incisor. So we need a higher connective tissue graft just in this case. So usually we use 4 millimeter always in the mandibular area. If the vestibule depth of the adjacent area is bigger, is higher, we use 5 or maximum 6 millimeters to regain that verticality that we would like to have in this area.
Okay. So, and the question I wanted to ask you about the non-carious cervical lesions, that the recent literature that we have tells us that we always have to restore these lesions. But in the 2011 decision-making paper, there was the first and second scenarios where if the flap is stable, you can solve this by just the surgical option of using a coronally advanced flap or a coronally advanced flap with the connective tissue graft to stabilize and not do a composite restoration. So is this now overlooked?
But because the let's say the abrasion was more located on the root, this is the reason why. So when the cervical abrasion is located on the crown, involves this is a step that is located on from the CJ up to the crown. So you need to restore it, or you need to combine these two situations. So if you have an abrasion in which involves crown and root, so you have to combine. So actually, it's the same thing.
Yes, but if the flap is stable, we can go for the connective tissue graft without the composite restoration. If the flap is stabilized 1 millimeter or more above the lesion.
Yeah.
Yes. Okay. Very nice.
The importance is to adapt the marginal flap over a convex surface. So it depends of where the borders of the lesion are located. So if the flap risks to shrink into the lesion, of course you have to restore it.
Okay. So let me ask you about something that's been knocking my mind. Do you think that the management of recessions caused by periodontitis could be different from the recessions caused by faulty brushing in terms of the choice of technique? Meaning that if we have periodontitis recession, maybe we go for the two-stage instead of the coronary advanced flap, or it's just about the nature of the tissue and the position of the teeth and other factors? Do you think that if the recession is caused by periodontitis, this might affect my decision?
I don't think it might affect the decision because the technique are those techniques that we have available. The point is that often when we have periodontitis, we have interdental soft tissue loss. So, along with buccal session. So in these cases, we have to evaluate what is our goal in terms of gingival recession associated with periodontitis. If we need to improve the gingival thickness in order to improve oral hygiene, or we need to improve aesthetics, or we need to increase keratinized tissue, especially in the mandibular area. So it depends on our goal, I think, more than the technique of choice according to which type of gingival recession do you have.
Okay. So then let me ask you about this reversing suture sequence, reversing the suture sequence that we start with the sling suture first and then the vertical. I really didn't get the point of this. What's the benefit of doing this?
Okay. The current advanced flap has been introduced suturing the vertical rising incision. When you have finished with the vertical rising incision, the surgical papilla are passively located above the anatomical papilla because you have free from tension the flap before. In the mandibular incisor area, it is a difficult area, which all those kind of surgical issues that I've told you earlier, we have reversed the sequence in order to make the vertical releasing incision, and especially the most apical periosteal suture more comfortable. So we start with with sling suture, we stabilize the coronal aspect, then we can go apically. We can pull a little bit in order to see perfectly the end of the vestibule, and we can perform the periosteal. In this way, it is easier to suture this kind of flap in this area. The sequence is reversed for to simplify the suturing in this anatomical area. This is the reason.
And it's mainly restricted to the mandibular recession, the lower recession.
The lower, the mandibular arch, even in this in the lateral posterior area, it's better.
And with the mandibular recessions, do you always go for vertical releasing incision medially, especially when doing the lateral approaches?
Yes, especially because when we, well, it depends of the dimension of the depth of the gingival recession. So if you have smaller recession, very small, in which the canine has the biggest depth, so you can perform an envelope flap exactly the same that you are performing the maxillary area, but you have to have a small recession, because otherwise the rotation, since the mandible is more squared compared to the maxillary area, is more difficult. In all those in other situations in which we have deeper gingival recession, and it is usually like this, we usually prefer to divide the mandibular area in 3 segments. So treating from lateral to lateral and from mesial to canine up to the distal area using a vertical receding incision, interrupting the envelope flap, basically.
So it's the recession depth that identifies this, or that decides this, the recession depth.
Yes, the recession depth at maximum 2 millimeters at the level of the canine. Yes. And the adjacent should be lower because the canine is the center of the rotation. So we have to, we need smaller recession in the adjacent areas to perform the envelope flap in the mandibular segments.
So we have 3 more questions and that's it. I know it has been a big effort for you, and we thank you so much for that. So last 3 questions. Vikander, if I'm saying it correctly, how to determine the clinical cemento-enamel junction in non-caries cervical leads? This is a long lecture, I think.
Yes, because always I've received this kind of question during the discussion. It's a long story. We have to calculate the ideal dimension of the interdental papilla needed to rebuild to reach the maximum root coverage. I suggest you to read the paper published in 2006 by Professor Zucchelli, Testori and DeSantis, and then Zucchelli 2011, in which you have everything well explained, because otherwise I think it could last at least 1 more hour.
Vikander, if you're interested, you can send us an email and I'll send you the paper. No problem.
Yeah, I can send you as well the paper. If you write me, not a problem.
Guiti is asking, do you prefer prevention of recession in thin biotype or waiting with the control? It's your picture posted on Instagram.
Ah, yes.
I don't get it.
Yeah, today I posted I posted some pictures regarding a very thin phenotype, gingival phenotype, but without recession, because it was a very buccally displaced root was present. So I asked it to my colleagues, which kind of, how do you usually manage this kind of situations? So prevention or follow-up? In my opinion, prevention, follow-up in this case, in the case I posted, is more than okay, because you don't have gingival recession, and we know for sure from the literature that tooth can be healthy even without keratinized tissue or a thick gingival, So follow up so far.
We have the last question from Hussein. It's really a very nice question. He says, do you think that we have to repeat the sling suture after doing the vertical ones with the reverse technique he means? We have to redo the sling suture?
Redo moving the knot on the other papilla. Yes.
Yes, sometimes you have to do that if the suture is not tight enough.
Yeah, yes. Absolutely. I agree.
Great. Thank you so much. I really can't thank you enough for today. It was very informative for everyone, and we really enjoyed your company. And we hope to have you again with our education club, and I hope you enjoyed too.
Of course. Thank you for the invitation. It was a great pleasure, and I hope you enjoyed my webinar with you today, and hope to come back very soon with you all.
Hope so. Thank you so much. Enjoy the rest of the night.
You too. Thank you. Bye.
Bye-bye.
Bye.